Good morning to CDC staff, program participants, and guests. My name is Robin Davis, and I'm a rising senior at Oakwood University studying health sciences. Today, I'll be presenting a literature review called COVID-19 as a catalyst for ageism in the United States. I developed an interest in this topic after being exposed to many age-related health determinants during my internship at New York City Department for the Aging. And through participating in holistic health programs designed for the elderly, I saw firsthand that many of these programs served as initiatives to restore social integration opportunities for the elderly due to COVID-19. I became interested in investigating other areas in which COVID-19 has impacted older adults and found that ageism, defined as stereotypes, prejudice, or discrimination against people because of their chronological age, has played a large role in the elderly population's deteriorating health status during the progression of the pandemic. During this presentation, I will analyze the relationship between COVID-19 social restrictions and increasing rates of ageism in the United States through identifying ageism's contributing factors, discussing its physical and mental impact on the elderly, and exploring possible health, policy, and education interventions. Several factors contribute to the prevalence of ageism during COVID-19. As the virus emerged and leading health organizations tried to identify its rates of mortality and morbidity, people over 65 and immunocompromised individuals were quickly identified as the groups most at risk for developing serious complications and fatalities. Society incorrectly labeled the virus as an old person's disease and placed an unbalanced weight of responsibility on older adults to stay isolated. Worse, the media's public messages toward the elderly became increasingly negative. Younger generations used the derogatory hashtag boomer remover to represent the virus's death rates among the elderly. Demeaning terms such as this indicate poor intergenerational ties between younger generations and older generations. Another contributor to ageism most often displayed through unhealthy competition fueled by urbanization and technological advancements. Additionally, studies have shown that highly masculine societies that emphasize competition and favor the strong also view the elderly as warm but frail and incompetent. This image displays the negative, however unintentional, consequences of pandemic control efforts as it pertains to the physical and emotional well-being of older adults. As social distancing measures were established with the goal to reduce community transmission, new cases, demands on healthcare services, and mortality rates, older adults experienced feelings of loneliness and isolation, reduced access to services, and a decline in physical and cognitive function while dependency increased. Ageism's pervasiveness began to quickly permeate into America's healthcare system, specifically the code of ethics behind many of the decisions pertaining to COVID-19 treatment. For instance, nursing homes across the country shunted aging and disabled patients into homeless shelters and motels, according to testaments from former residents of Lakeview Terrace Nursing Home in Los Angeles. Nursing homes began to accommodate COVID-19 patient overflow in local hospitals by discharging elderly patients and forcing them into unsafe housing facilities or homelessness. Larger hospital systems were faced with ethical dilemmas of a similar nature. The ongoing health crisis created medical supply shortages where medical professionals had to choose where to allocate resources and life-saving interventions. Prioritizing younger patients became a harsh reality for hospital staff, a decision that supports the ageist medical stigma that achieving the most good through health interventions is only possible with younger adults, whereas higher rates of disease complications and death rates are only inevitable parts of aging. Ageist attitudes and practices have an immense impact on the holistic health status of older adults, as studies have revealed. Degrading stigmas cause negative self-perception, which is linked to anxiety, depression, sleep disturbances, and loneliness. Extended periods of quarantine subject the elderly to risk of living a sedentary lifestyle, which increases the risk of developing bone degenerative diseases such as osteosarcopenia and osteoporosis. Lastly, decreased opportunities for social integration ultimately cause older adults to lose out on health benefits of social support, such as heightened self-esteem, positivity, and psychological support. Interventions for the elderly that will help them to cope with social isolation include positive diet and exercise changes, cognitive stimulation, and strengthening social connections. Displayed here are the results of a mental and physical wellness study conducted by psychiatrists located in London. The study, called Chariot COVID-19 Rapid Response Study, was performed to assess the impact of COVID-19 and its associated isolation periods on the mental and physical well-being of the elderly. Results from the 7,127 men and women participants with a mean age of 70 between the months of May to July 2020 showed a strong association between loneliness and worsened feelings of depression and anxiety. The World Health Organization attests that a society is measured by how it cares for its elderly citizens, With this understanding, society is called to dismantle ageist behaviors and attitudes through creating interventions in policy and law, educational activities, and within intergenerational interactions to foster lasting change during and after the COVID-19 pandemic. Approaches to implement civic education involve a threefold focus. Activities that integrate cognitive, socio-emotional, and behavioral aspects are highly effective when incorporated into school curriculum. Healthcare professionals are also called to address ageism within various components of caregiving, from initial assessment and planning stages to outcome evaluation. Medical practices and assumptions that are rooted in ageist stereotypes must be identified and discontinued. And lastly, members of the aging population must be involved in policymaking procedures, as they can provide useful insight regarding avenues of elderly patient care. The aforementioned interventions may improve intergenerational bonds and positively influence quality of care for elderly patients during COVID-19, thus reducing ageism's biological, psychosocial, and mental impacts. At this time, I'd just like to thank Dr. Jacqueline Berman and Dr. Mebane Powell at the New York City Department for the Aging for their guidance this summer. I'd also like to thank Columbia Summer Public Health Scholars Program for an incredible opportunity, as well as Danielle Joyner, Alyssa Watson, and Dr. Robert Folilov for their mentorship. Thank you so much for your time.